Top Med Talk.
Today's Top Med Talk is a two-part piece.
I'm Dave Walker. I'm an intensive care consultant and perioperative medicine enthusiast. This afternoon's final session is to try and do a bit of a deep dive into this thing, perioperative medicine, and how we go forward with it. And leaning very much on the inspiration of trainees, fellows of past, and trying to understand what it is they want for the future and to have a voice resonating in Ireland and beyond. So perhaps for a second, I could just ask each of you, just introduce yourself and tell us a little bit about you for a second.
Well, I'm Kim Caulfield. I'm currently a Perioperative Medicine Fellow at UCLH, having CCT'd in anaesthesia and ICU in Ireland in July 2018. And I'm currently also completing my Master's in Peri. I've always kind of had a vested interest in high-risk anaesthesia, but with a particular focus in obstetric anaesthesia, and having also completed a previous fellowship in the Royal Women's in Melbourne. Currently at UCLH, I'm increasingly understanding the increasing need for pre-optimization of our high-risk patients, not only pre-surgery, but actually enhancing their care in the PACU setting and post-op setting. I organised today's session because I do feel that there's a growing invested interest in Periop in Ireland, and I think we have a very good group of enthusiastic trainees, fellows and young consultants who have all previously done fellowships in perioperative medicine who are keen to drive this concept forward.
My name's Isra and I live with Kim, so that's why we're allowed to be in the same room together. So my name's Isra Hassan and I am a post-CCT anaesthetist who did the majority of my training in Wales. So most of my interest lies in perioperative medicine and education. So in my final years as an anaesthetic trainee, I sat on the Royal College of Anaesthetists Advisory Board for Wales, the Academy of Medical Royal Colleges, as well as the Welsh anaesthetic group. So I had a heavy involvement with education, and from that enthusiasm for Periop, developed a foundation programme for doctors in Cardiff and Vale, South Wales, in which we've got over 150 junior doctors through, developing more of a postgrad programme for anaesthetists, but also looking at developing a programme for recovery nurses as well as PACU nurses. Back in 2018, I co-founded the Welsh Perioperative Medicine Society with Dr. Hugh Evans, a consultant anaesthetist in Cardiff. Now our college are running, and hopefully give you a bit of insight of how we developed that and some advice, and hopefully have a good discussion today.
Padraig of Scanaill is my name. Previous Perioperative Medicine Fellow, having worked at UCL in London, then going on to do Senior Anaesthetic Fellowship in Liver Transplant and Cardiac Anaesthesia. I guess it ties in nicely to my interest in evolving post-operative care for the high-risk surgical patient. An anaesthetist by training, I guess, and then after coming home on the ship from the UK, currently working as a Locum Consultant Anaesthetist in the Mater Hospital in Dublin, where I'm keen to evolve a very exciting service that they have there in terms of perioperative medicine, in terms of, again, that focus of interest of a high-risk surgical patient. Not quite the patient that's a candidate for high dependency unit, but yet not quite the patient that's in the ward level care. So that would be my area of interest, together with medical education, which I've done some additional training on.
I'm Aislinn. I'm working currently in Melbourne. I am currently working at Peter MacCallum Cancer Centre, which is a quaternary cancer referral in Victoria. Also takes patients from some of the neighbouring states as well. I have completed my CCT in Ireland, and I spent my last year there working with John Buggy as the inaugural Onco-Anaesthesia Fellow. So my interests at the moment are in the management of the high-risk cancer patient, and particularly the peri-operative package that we deliver for those patients. And I suppose, given my previous life as a physiotherapist, I'm also interested in the patient side of things. I'm hoping to take up my post in St James's in the new year, keen to get involved in setting up some high-end cancer management of those patients there.
I'm Andrea Haren. I was a Perioperative Medicine Fellow Contemporary Perioperative at UCLH, so 2018 to 2019, having CCT'd in anaesthesia in Ireland in 2018. During my time in London, I spent also time in Guy's and St Thomas's working with the POPS service there. So that's the Perioperative Medicine for the older person undergoing surgery. In that time, I developed an interest in particularly perioperative management of the older person undergoing surgery, and with a particular interest in developing collaborative pathways and kind of integrated models of care with cross-specialty approach, and liaising closely with medicine for the care of the older person. So Since I came back from London, I've been working as a locum consultant in St Vincent's Hospital in Dublin, and we're doing some work in trying to replicate some of the practices from the POP service, so particularly trying to build some relationships with the medicine for the care of the older person specialists in Vincent's who are enthusiastic and keen to get involved. So
I'm Roisin Coary. I'm a final year geriatrics SPR, and I developed my interest in perioperative medicine having rotated through an orthogeriatrics post as a trainee, and just really saw the benefit of it. And subsequently, I went on to do an out-of-clinical programme fellowship year in Southmead Hospital in Bristol in perioperative medicine for older people. And it was there that I worked with patients primarily under the care of gastrointestinal surgeons, but also vascular surgeons and trauma patients. And again, like Andrea, just developing links with the anaesthetists and the surgeons in the hospital there and kind of formalising pathways. And subsequently take that experience home. And I'll be finishing off the rest of my scheme as acting up as a locum consultant in the Mater Hospital in the next few weeks, having been off for the last few months on maternity leave.
So we're going to have a trot through a whole raft of topics. What is training? What is perioperative medicine? What's experience? And how do we get trained for this job ahead? So I'd like to begin with pre-assessment. It seems like the place to start. And someone wants to talk about who should be pre-assessed. It's a universal question, whether you're in Dublin, Ireland, Singapore, or here in London.
Everyone coming for surgery should be pre-assessed, but I think in terms of who should pre-assess those patients is quite important. And I think that links into the next topic of triage. So if we can identify every patient coming for surgery or needing surgical intervention and are able to do the pre-assessment early, then we can triage those patients according to their need to have a consultant-led assessment, be that face-to-face or virtual, a registrar-led assessment, or even a nurse-led assessment. Now, there's different adjuncts that could help us. For example, we could give the pre-assessment early, be it patient that we can do at a surgical clinic at time of decision for surgery, or we could invest in kind of online apps, like such as the Periap App, where there's onus on the patient themselves. Once they get assessed for surgery and decisions made for surgery, they can log in and do their own pre-assessment and maybe answer questions in terms of their past medical history, their own medication list, and previous anaesthetic or issues or complications. So that information is already kind of inputted into our system. So then when it comes to triaging the patients, we can do it a lot more efficiently. And particularly for the higher risk patients, we could maybe identify those patients who maybe need to get that echo from the other hospital that they previously came from, or maybe need to get more information from the GP. So all that work can be started before we actually see the patient in clinic, just to make the process a lot more efficient. That's my take on the experience I've been getting here at UCLH in terms of pre-assessment, which I think is working quite well with our online electronic patient record and the advancements, particularly with COVID and virtual clinics.
And Kim, I was struck by that data dating back to 2011 now, with a strong association between going to a pre-assessment clinic and outcome. Maybe, Kim, are you able to just give us a quick thumbnail of what goes on at UCLH or anywhere else you've worked? What is this triage system you talk about?
The Periap App is a concept that can be implemented into any electronic record in any hospital system. It has clinical governance to the app already and this data protective element to the app already. So the idea is that every patient can log into the app onto their phone or onto a computer, and they can input their own data into that app, and we can preset the data. So we can preset what information we want in that patient. So not only can you get pre-assessment, you could also probably link in kind of risk factors. So if you wanted to do a frailty assessment, etc., you could probably all link that into the app. And then that information then will be fed back into your system and will allow you to do a better and formalised triage. It's currently been implemented in UCLH and being looked at because of the need for virtual clinics. And we can integrate it into the Epic format that we have already. This can be done, if you don't have a electronic patient record, obviously this can be done in paper format. So this could be a paper assessment that could also be done at the time of the surgical clinic and the time the decision is made. So it is versatile. It's how it's implemented. And it can be adapted to whatever hospital system is being used at the time.
Got it. I mean, it sounds this UCLH place you work is very far advanced with apps and things. Anybody else got any experience of less advanced pre-assessment services. I haven't seen that app yet, but I know it exists, and I know that there's a great appetite for using it. Perhaps I'm in the wrong age group for using it. Anybody else in the group about triage? Should we be seeing everybody? What's the score here? Should everybody be seen?
So I guess globally, not just in Ireland or within the United Kingdom, it's largely a nurse-led service, be that by the telephone, the involvement of video conferencing services, and the opportunity that COVID has given us to really take ownership of this perioperative pathway for patients, particularly pre-assessing these guys. What Kim mentions in terms of the triage, I think, is really important. Risk scoring, getting the proper indexes for these guys who we come in, who we think may do okay, and who we can say, look, let's robustly tele-assess them and say, look, on the day, you should be fine to go, and then we have their post-operative pathway planned. The difficulty is that we're seeing an aging population, increasingly complex surgery that's being inundated upon us, and COVID has given a little bit more complexity to that insofar as that all this elective surgery was cancelled so that we could scramble to treat the population and get our well-deserved claps on a Thursday evening at 8 o'clock. But the patients have gotten sicker. They haven't been pre-assessed. So there are cohorts coming through now for sure. If we could remotely tele-triage them, this application that Kim mentioned for sure is very helpful. And it's just so that we plug them into the right place for afterwards. I think the pre-assessment bit of a patient assessment is pretty good. We're obviously finessing it, particularly in the UK, the idea of a PQIP, or the Perioperative Quality Improvement Project, getting anemia, diabetes, frailty, getting those bits, those seemingly simple bits, we don't always get right. Getting those bits right is great work, so that we can try and optimize it. And then I guess the biggest word of 2019, prehabilitation, plays into that as well. So timely referral, triaging them, so we say, look, you need a bit of prehabilitation, you need some treatment for your anemia, get some iron, whether it's good or not for you is up for debate, but just having that open discussion with the general practitioner, the primary referral team, and then getting your allied health guys on board pre-operatively, I think is of benefit.
I'm interested to know what you guys think of whether this is a job for an anaesthetist. Where do you stand on that? Isn't this more a general practice surgical thing, or do you feel really invested in this part of the service? Anybody got any experience from outside of UCLH?
Like, as a geriatrician, I obviously have a vested interest in this, but the majority of people going for surgery now are older, and you're seeing older and more complex and more frail patients going forward for surgery. And I think, from a geriatrician's perspective, I want to see all those people being pre-assessed. And my experience in Southmead, we had a parallel pre-operative assessment clinic in conjunction with the anaesthetist. So it was separate from the standardised anaesthetic pre-operative assessment. And most of our referrals came through the surgeons, but also through anaesthetists.
So I suppose our experience is that we try and both stage the patient and stage the disease. So we would try and get our patients into pre-assessment for triage whenever they kind of present to the hospital and get that process going early. So if there's any opportunity for them to improve themselves while undergoing neoadjuvant treatment in terms of prehabilitation, there's time for us to do that. And in terms of the question of who should do the pre-assessment, I think as anaesthetists we're uniquely placed to understand both the rigors of the surgery that the patient is having, as well with our in close alliance with intensive care medicine, the post-operative complications too. We would do a lot of shared decision-making clinic work here with our high-risk patients in terms of their disease burden and their outcomes or predicted outcomes, and ensuring that they understand, I suppose, what their risks and benefits are post-surgery, in conjunction with the rest of our MDT colleagues. So in conjunction with our pharmacists, we've got very close liaisons with our general medicine physicians, geriatricians, and our oncologists and surgeons, as well as our intensive care colleagues here, who would all contribute to that discussion around the patient outcome.
We've got a question on Slido, which it slightly turns that on its head, but so it's a team anaesthesia focused question, but should all anaesthetists be doing pre-operative sessions, or should it be an area of special interest for those who wish to do it? From Andrew L.
I've seen both sides to this, and I know there's an argument here that I think especially when in this service, that's quite, I suppose your time pressure and Padraig to get lists through Padraig and then to take a anaesthetist away from Padraig to do clinic can be quite difficult at times. But I think that over time, that benefit has massively been proven to improve patient outcome, patient and patient experience. At UCLH, clinics are run as per specialty. So I think it's really, and I've seen in hospitals in Ireland as well, where anaesthetists are seeing and even doing chart reviews of the patients from clinics they're going to anaesthetise. So I think the workload has to be shared amongst the departments. Not necessarily that one person should be doing all of it. I think the benefit for the patient is if, one, that they're being pre-assessed at any capacity, and then decisions are being made by those patients within the same cohort of anaesthetists, it being specialty specific. I think that's important. I know maybe Roisin has probably spoken to you previously about the pre-assessment we did for all patients in Bristol by geriatricians, especially the high-risk patients, but maybe that might be something that could lend to the discussion here.
Definitely, when we were seeing patients, you see them primarily for the purpose of, pre-assessment or why they've been referred. And I think this is the value of a pre-assessment or them seeing a geriatrician, but the amount of times you picked up separate issues that weren't in any way related to, say, the initial surgery, but would certainly form a part of the discussion or the shared decision making. I think, the amount of undiagnosed cognitive impairment, I think up to a third of cognitive impairment or dementias in the community are undiagnosed. So you're given an opportunity to see these patients, to assess them and make that part of the discussion. And if you weren't seeing them beforehand, that, the only way that might manifest itself is kind of post-operatively with a delirium or further cognitive decline. And you're given a chance to pick up on that. Same with, levels of frailty or, that could be modified to an extent. Nutritional assessments, again, these are all modifiable factors. And just, to plan, it gives you ample opportunity to plan and be part of the decision-making process.
Another question from a chap called Mike Swart. The name will be familiar to many of you.
Oh, okay.
I have to read out the whole question for reasons you'll understand in a moment. Should you change the name from pre-assessment to preparation for surgery? And this really chimes with what Ravi Mahajan, the president of the Royal College of Anaesthetists, has been talking about relating to changing the notion of waiting lists to preparation lists. And then full stop, or am I too old to join in, question mark.
This has gone from an expert panel to putting you all on the spot. But I think it's a great question, and I think you have the experience to get straight back at that old chap Mike Swart and tell him your answer. Anybody want to challenge Mike Swart?
Well, I agree with the idea of thinking of pre-assessment as more than just a medical kind of a list of comorbidities, medications, a checklist, and that's been my clinical experience working in settings alongside geriatricians and now trying to lead something anaesthetic-led in my current context. Interestingly, I think the policies in Ireland lend themselves to that more innovative kind of holistic approach to pre-assessment. So when you look at the HSE model for elective care policy, that puts medical assessment as just one aspect of a multi-domain, thinking about functional, cognitive elements that we don't describe typically in a standard medical assessment. And I suppose for Roisin and for me, that sounds like, and for comprehensive geriatric assessment type approach where you're thinking of a multi-domain like approach to the patient. So I think the idea of preparing someone, because it's not just about the medications, it's about the undiagnosed cognitive impairment, the risk of functional decline, all of these things that maybe need to be actively elicited and discussed and addressed. I would support the idea of thinking of it more of an opportunity to intervene rather than just to list a number of problems and say, this is the estimated risk of the surgery. It should be an opportunity to do a bit of health promotion and some proper shared decision making.
Yeah, you said it. I thought you'd get all the way through that without saying that word, shared decision making, because clearly that sounds like what you're articulating to me. Anybody have experience and more confidence perhaps than they ever did have as an anaesthetist with this concept of shared decision making, walking the journey with the patient and asking some difficult questions, what matters to you? Anybody got comments on growing into that role?
Yeah, so it's in Peter MacCallum, it's something that's quite frequently done. We have a very close-knit MDT working group who look after our fit for surgery and schools. So anybody can refer a patient into the shared decision-making clinic, which happens usually once a week or so. So when the patients are screened, there can be highlights on that might be some potential issues. The nutritionist can refer in the physiotherapist when they're doing some rehabilitation or prehabilitation rather with the patient. And I think the shared decision-making, I think there may be a worry that we're trying to talk a patient out of surgery, but I think the importance for the patient is understanding their options a little bit better, and giving them the decision to make that themselves in the full knowledge of what potentially could happen. And we would use quite commonly a best case, worst case scenario. So over a couple of meetings, quite a patient, we would usually meet them initially, have a discussion about their hopes and goals, essentially questions like, is there something that's worse than death for you? And often we hear from our patients, well, being incapacitated or losing my functional ability or not being able to live at home with the grandkids. Those things are important to patients and maybe not fully elicited when we're consenting patients for surgery. So we will take those goals away and have a chat with our surgical colleagues, our rehabilitation medicine colleagues and our physiotherapists and see where that patient may sit on that best case, worst case scenario. And we'll return to the discussion with the patient and potentially someone that they've nominated as their next of kin or relative who's going through this journey with them, who will then make that decision for themselves with a recommendation that we would say, well, we think potentially this is your best option, but we're willing to what you want to do and what sits best with your goals.
Yeah, and the term surgical school, does somebody keen to articulate what that means? You've described a group of interventions at clinic. Are they all brought together under this broad term surgical school? Has anybody got experience of running this sort of one-stop surgical school where all of those things are addressed?
So we essentially run dual clinics now. I suppose in terms of geographic area, we're used to telehealth medicine a little bit more, and that's been ramped up now with the pandemic this year. So we can have exponential number of patients who are going through a day's worth of virtual surgery school where they'll hear physiotherapists in terms of getting up and about and what they should expect preoperatively in terms of potentially prehab, and then postoperatively in terms of things like pulmonary toilet and ACBT techniques that we teach patients before they come in to reduce the risk of pulmonary incontinence. We'll also get a nutritionist to chat with them. I think somebody from the pain team frequently chats with them as well, expectations of what way we may manage their pain. And then obviously an anaesthetist will have a chat with them about the anaesthesia side of things. And I think the benefit of surgery school, keep it quite broad, and this will cover a lot of patients who may not need that full workup in terms of pre-assessment. And I think the patients are very happy with that they have a better understanding of what the process might be. As for some of them, it might be their first trip into surgery or trip into hospital for major surgery.
Yeah, I also think that it ties into the improved patient experience. As in UCLH, we do it for the more complex kind of oncology patient who might need a lot of visits to hospital, and commuting in London isn't always the easiest at the best of times, not alone with COVID. So trying to get all of those necessary appointments done on the same day, and that they're seeing the physio, the dietitian, the pharmacist, the anaesthetist and the surgeons all collectively, and then there can be an MDT discussion at the end of the day. It might be an intensive day for the patient, but at least they get exposure to the necessary information that they need pre-surgery, because it all then ties into the idea of shared decision making, why I think that's so important, because if we improve a patient experience and improve their reported outcomes, that could actually be in itself the benefit to pre-assessment that we probably, and to perioperative medicine, that we probably need to kind of take a greater focus and assessing that benefit through our intervention, as well as obviously the financial and the efficiency that the service can provide by changing to kind of a holistic approach to the patient. But I think if we start looking at patient reported outcomes a little bit more and tailoring how we deliver our service to that endpoint, we might get better patient outcomes.
One point on that, sorry for cutting across, just to say that patients, when you speak to them after the one-stop shop day of intensive 8 a.m. till 3 p.m, seeing everybody, they actually come out of it going, gosh, I'm really tired, but that was great. I'm really thankful. And certainly seeing that in UCLH in London, it was surprising because I was thinking that they'd say the opposite, but actually they're better informed. They've had that discussion. They've had the options, and that shared decision really, truly did happen. And the barriers are there for sure to try and get the logistics right, to get the right patient in to see all these people. But certainly from seeing how in London, it's something that for sure we can do in Ireland. It just take a little bit of thinking to get over those barriers.
I'm really keen, maybe Andrea, putting you on the spot a little bit about how it's been as an anaesthetist getting immersed in comprehensive geriatric assessment and that MDT stuff, that shared decision-making stuff, as an outsider. You know, we were dipping our toe in the water, weren't we, at UCLH? And then you crossed the Thames and you really got immersed with a group who really do it properly. And there are other groups, of course, but what was your experience as an anaesthetist?
So I think, first of all, a little bit when you start to see it in action, with the multidimensional aspect and thinking about the different things that you have to actively seek, that don't come up in your standard medical assessment, that was a bit of an adjustment. But when you look at, for example, the AAGBI guidelines for perioperative care of the older person in, 6 years old now, that's, if you look at the model of what comprehensive geriatric assessment is, that is a multi-domain, so thinking about medical, functional, cognitive, social, that models quite well to what the AAGBI guideline is. It's comprehensive geriatric assessment it's another name for maybe what we're encouraged to do as anaesthetists anyway, which is particularly with the older person, think about actively seeking out cognitive impairment preoperatively because, well, for a start, it may impact on decision making, or there may be things that need to address before undergoing surgery. It may expose them to an increased risk of delirium, and that could be something that could just be communicated back to family, to medical teams that will be looking after them afterwards. So an opportunity to address that. Functional status, which is obviously something that we're thinking a lot about as anaesthetists. So whether it be, CPET assessment or the DASI measurement, or these are things that we are encouraged to think about as anaesthetists. And again, in the comprehensive geriatric assessment, it's that by just another name. So you might be using the timed up and go, you might be using chair stand, but it's just another way of assessing the same outcome or the same domain of someone's function. So I suppose, although initially it felt different, the more I worked through it, the more I was like, these are the things that I think we're asked to do as anaesthetists, actually. Maybe I didn't have the confidence to do it before, and it's just given me a bit of the skill set to start to do it in practice. And practically what that's meant for me at the moment is just trying to, for the older cohort that come through our clinic, so at the moment just the over 65s we're starting with, but we're adding in cognitive assessment, functional assessment, and a frailty scale or a frailty score for all of those patients, with the aim of characterising a higher risk cohort that we can flag to our medicine for the care of the older person colleagues who are really keen to take an active role in this collaborative perioperative pathway. So maybe in guys in that service, the POPs team take the whole process under their wings. They'll start with the pre-assessment and they'll follow the patients up in the ward. That's maybe not something that resource-wise we're in a position to do in the hospital I work in at the moment, but we do have colleagues who are, really interested in getting in earlier in the patient perioperative pathway, because these older patients, frail patients, are patients that the medicine for the care of the older person specialists are seeing at some point in their post-operative stay, but not necessarily at the, maybe later on in their stay when they've lost a bit of their functional independence and they've, had a few complications that set them back. So their motivation is to try and get in earlier too, and we just need to flag what we think are the higher risk patients for developing those complications. So.
Got it. Thank you. I'll come to Mike to close this first part of the session in a second. I wanted that to be a little bit free-ranging, really. I wanted to scatter a whole raft of topics there. None of those sounded particularly anaesthetic by traditional senses. And I just wanted to get a feel across a broad range of pre-assessment topics, what you guys were involved in and what your experiences were as an introduction to this session. I think you've demonstrated that quite well. We are talking about something different, but something that embraced by anaesthetists and something that anaesthetists have something to offer. Mike, do you want to just close the pre-assessment bit out with a question from the audience?
Yeah, we've got a couple of linked questions relating to MDT. So the first one, both from anonymous contributors. The first one is, isn't it time anaesthetists became more involved in surgical MDTs? Obviously, in places they are already, but I think important question. And then the linked question, how do we get hospitals to pay for anaesthetic involvement in surgical MDT?
That second one's a bit of a grown-up question that I still don't feel qualified to answer. It's about engagement and changing hearts and minds and all of those sorts of things. Anybody have a more constructive comment to that?
Well, just to say that the more I've learned about I think there's some exciting opportunities in Ireland that are mandate or kind of articulated in policies that are coming out from the HSE. So one that is relevant particularly to older people is the integrated care for the older person. So that's a national policy that articulates a kind of integrated care pathway, not just for the surgical patient, it's for anyone having contact with medical services, but it tries to envisage how you can age at uniservice and acknowledging maybe that there's not going to be massive changes in the way our hospitals are run. It's just going to be trying to work around the pathways that, so getting it, I think, trying to get involved with surgical MDTs would be an obvious way of trying to see those patients earlier on, or trying to, be part of the conversation at the start, because we tend to see our patients very close to the date of surgery. It feels like there's been a missed opportunity earlier down the line. We're kind of learning about them later. So I think the policies are telling us that we should be thinking about the patient, like patient-centered care, everybody trying to work around that one person having their diagnosis and having their treatment. And it's just about trying to see how practically we can affect that within our healthcare system. I suppose encouraged by the policies tell us that that's what we need to be doing. I think maybe that implies there might be funding opportunities, but maybe not right now when everything is diverted.
I just wonder whether we need to be honest with ourselves and agree that the current model is broken. I think if we want more productivity, the current system will not allow it. We're leaned out, aren't we? We've done just about everything we can. We need to think about things differently for sure. And perioperative medicine is probably the most refreshing thing I've seen in years, but I would say that.
Top Med Talk. Thanks for downloading Top Med Talk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn and YouTube. And also, don't forget, Top Med Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.